disease. So we are between blood fever and COVID fever. So I think it's an apt topic. And also, Kanji Kamagodi Trust, they have brought so many interesting cases and case reports of the COVID also. I think it's published also. So I think he's the apt speaker. Without wasting much time, I wish the CME program all the success. Thank you for inviting me here. Jai Hind, Jai IAP. Over to Shanai.
Yeah, thank you, sir. Thank you very much for your kind words. Before we move on to today's academic session, I sincerely thank all the members of IAP Kannur for conducting ORS and World Breastfeeding Week in a big way. Thank you once again. Now I request Dr. Ramesh Kumar sir, who is the moderator for today's academic session and who is also going to introduce the speaker. Over to you, sir.
Respected President of Kannur branch and chairperson for the meeting, Dr. Shanai, Secretary Dr. Muhammad Irshad, South Zone Vice President and Chief Guest of the Day, Dr. Ananda Keshavan, President of IAP Kerala, Dr. Narayan, Secretary Dr. Balachandran, my great friends in Kannur, especially my dears, Dr. Nandakumar, Dr. Ajit, Dr. Ansari, the seniors there, Dr. Subramanian, Dr. Prabhakaran, Dr. Venugopal, Dr. Sushama, Dr. Ajit Menon, Sulfi, and so many of the great friends from Kannur. My other great friends from Kerala, Dr. Jivaraj, and our past president, Dr. Parvati Ma'am and Dr. Vinod Jacob Chirian. And I will see a lot of good friends from outside Kerala who are logged in for the great session which is anticipated here. Dr. Pajapati is here, Dr. Dariru Ranganath, Dr. Venkateswar Rao, Dr. Gautam Ghosh, and I can see even Dr. Ashwini is here, the infectious disease expert from Shimla was joined just now. And lot many good friends from outside Kerala. Dr. Gladita Kailas is here, HOD Pediatrics, Trivandrum. Friends and my dear friends who have logged in from outside the state as well as from Kerala and of course from Kannur. Friends, it's an exciting evening here today where we have a wonderful speaker with us, Dr. S. Balasubramaniam, for the scientific session. And as for a formal introduction to Dr. Balasubramaniam, SBS as he is known everywhere, S. Balasubramaniam, is not of course needed. But I must recollect or recall at this point that Dr. Balasubramaniam is one who has got 34 years of experience in pediatrics, but I must say clinical pediatrics and teaching experience. That's awesome, dear sir, because the way he has done he has got around 34 years of experience, as well as he had done around 500 sessions in various CMEs and PG training programs, and he had done around 10 orations. He was the examiner for MRCPCH UK, and he had about 90 index publications as well as 10 chapters in books. And he's got a lifetime achievement award from Tamil Nadu Dr. MGR Medical University. And more importantly for all of us, what is known as, he is a very good OSCE examiner and one fellow, one teacher who is unbeatable on infectious disease. And I have listened to him talking many times on antibiotic choice, of course, in any scenarios, and any number of times you listen to him, you have got something else to gather. And I have actually made a note of what Balasubramanian sir has said in at least 3 or 4 points in every session, and that itself has gone into a voluminous pages. So that speaks volumes about you, and the good number who was out here to join you itself is a credential to the way you are, I say, the clinical sessions. That really comes from an astute teacher, astute clinician like Dr. SBS only. And the topic for the day is the most interesting session, I must say, the antibiotic choice. Of course, you have got a lot of dilemmas. Even after 25 years, I feel still may think for a minute which antibiotic, because being a rationalist pediatrician always wonder which is the optimal antibiotic or which is a narrow spectrum antibiotic or which can be the defined antibiotic for this particular scenario. So the dilemmas are there, and when the dilemmas are there, you must have the solutions around. So of course, the solutions must come along with the dilemmas. We cannot go on wondering about it, and that's where Dr. Balasubramaniam will take us there today for this session. I now invite Dr. S. Balasubramanian sir, the great teacher, for today's scientific session, and requesting Bala sir to have the scientific section ahead. Dr. Bala sir, please. Bala Subramanian sir. Bala sir, are you muted? Sir, you may have to unmute. I'm not sure.
Good evening, friends of. Am I audible, Ramesh?
Yes, yes, sir. Very much, sir. Fine, sir.
Good evening, friends of the Indian Academy of Pediatrics of Kannur, Kerala, and other friends of the IAP, many of whom I'm seeing who have logged in. At the outset, I am grateful to the organizers, particularly the organizer of the Kannur branch and state chapter president, secretary, others, and Dr. Ramesh Kumar for giving me this opportunity. You must all be wondering this topic of antibiotic choice, what is going to be new? I don't think there is anything new in my session, but I thought I will take up a few case scenarios in office and a few in hospital practice, where a general pediatrician like me faces dilemmas in instituting appropriate antibiotic therapy, particularly in choosing the right one. Then I'm going to audit those prescriptions, which are commonly given by all of us, including me. And I'm going to divide those into imperfect ones and perfect ones. And at the end, I'm going to ask you all a few questions, in the sense, discuss with you, where are we and why are we at this stage with regard to antibiotic practice? And then suggest the way forward for getting all of us out of this mess. Let us get on with the first scenario itself. I've named it throat infection. The reason why I put it as throat infection, a child with throat infection, is very simple. You know, it's one of the most common symptoms, a child having fever and throat pain. And the mother invariably would come to us and tell us the child is having throat infection. And they would also say the father or the mother is also having throat infection. And the neighboring ENT surgeon would have prescribed azithromycin for the father. The child would have some cold and cough, and the tonsils will be red, throat will be red. Then the young pediatric practitioner who has just passed his MD would always ask, how can I not give an antibiotic? Father is already on azithromycin. And he prescribes amoxicillin. This is what is happening routinely. My question is that correct? Let us try to audit the prescription. Before we audit the prescription, we must know a sore throat may mean so many things. A throat infection may mean so many things. What the parents say is throat infection, for them it is bacterial. And I can tell you, no malice to ENT surgeons. ENT surgeons, always it is bacterial tonsillitis. For the pediatrician, the diagnosis is endless. Look at the 4 pictures here. The one here, you see here, some erythema is there, some vesicles are there in the soft palate. You know that this is viral, most probably herpangina or coxsackie viral infection. This is throat infection for which you are now going to prescribe antibiotic. See here, the tonsils are not very red, very dirty, but you see some exudates. I'm sorry. You see some exudates here. The tongue is normal. The palate is okay. Look at this one. Sorry, the video film is hiding it. But if you see here, the tonsils are fiery red. There are exudates. The lips are red. And around the lips, there is some skin lesion, perioral, circumoral pairer with mild exfoliation. Look at this. This also is throat infection. What you see here is red tonsil, but what you see here is a dangerous yellow exudate. So this is herpangina. This is viral, most probably EBV pharyngotonsillitis. This all of us know, very commonly seen in your Malappuram area in Kerala. Sometimes we do see from Andhra, diphtheria. And this is typical scarlet fever with circumolar pallor, beefy red tonsil with exudates. Why am I putting these pictures? It's very, very easy to make a clinical diagnosis of bacterial pharyngitis versus viral pharyngitis and diphtheria and even EBV. In fact, if this child has got, if you are able to palpate the spleen and if you find periorbital edema, it's very much likely to be EBV. And some of these children who have vesicles like this may have features of hand, foot, mouth disease. And diphtheria, you know, unimmunized child, drooling, lymphadenitis, bull neck, toxemia. All this can be clinically diagnosed. But then we keep on prescribing antibiotic. When I say we, practitioners in general, without going into the basics. What is the basic thing that you should do? When the moment you see somebody whose parents say child has got a throat infection, your question is antibiotic required? It's very simple. You can keep this in your table in your clinic. This is what is called modified McKissick score. Most of you don't use it. See, this is very simple. You ask yourself, what is the age of the child? The age is 3 to 14, the score is 1. Age is 15 to 44, it is 0. Or you can even practice this for adults. If it is above 45, like me, it's -1. First is age. Second is fever. More than 38, you get a score of 1. Absence of cough, it favors bacterial pharyngitis, gets a score of 1. Tender lymphadenopathy in the neck, jugulo-digastric, you get a score of 1. If you find tonsils are swollen or having an exudate, it becomes 1. So the maximum score somebody can get is 5. And with this score, which can be done in 20 seconds, 30 seconds, it doesn't take much time. Of course, in the COVID days, we always say don't use tongue depressor. From a distance, you can see the throat and identify. If the total score is anywhere between 0 to 2, you don't have to do anything. And of course, this article says anywhere, even for 2 and 3, if there is high risk, you do a culture. But then below 3, you don't have to do anything. 4 and 5, the options are: 1, if you are really convinced it is bacterial, you can straight away give antibiotic. There's no need for testing. But what we do in our institution is to do a rapid antigen test for streptococcus. This is something which is very simple. I do it in my clinic. I do it in my OP. You can do it, and within 3 minutes, you get the result. All you have to do is to put a throat swab, put it in the dipstick, which is available. It costs only around maximum of 750 rupees. And if you buy in bulk, you will get it about 175 rupees from the distributor. The same companies stand by what distributes so many other kits, supplies it. Some Japanese kits are available. They are now very easily available. If you get it, I will get you. What we did, our own experience with RADT was that it's got an excellent specificity and sensitivity, 98.4% to 94.6% of positive predictive value. And this can be easily done. If it is positive, you don't have to do anything. Culture is not required. You can straight away give amoxicillin. If it is negative history, we still strongly suspect you can do a culture. But you need not do it if the score, McKissick score is less than 3. 4 and 5, you can do rapid antigen test, which has got good predictive values, can be simply used. Then coming to the antibiotic prescriptions in throat infection, what do you think is the right one? The right one is application of modified McKesson score and usage of rapid antigen tests. And of course, prescribing amoxicillin for 10 days on clinical or lab diagnosis with RADT. And if somebody has got penicillin allergy, amoxicillin allergy, then you can prescribe azithromycin. What is imperfect or incorrect? Anybody with sore throat, the mother says throat infection, antibiotics. It's not correct. Preferring azithromycin, it's not correct. The reason is very simple. Azithromycin is bacteriostatic against beta hemolytic streptococcus. And the amount of resistance in India to macrolides is to the extent of 25 to 50%. Though it is easier, cheaper to give, we should not be wasting the antibiotic. Failure rates are very high. I myself have seen lots of failure due to azithromycin. And giving amoxicillin routinely to anybody with sore throat, that also is correct. And of course, there are papers which suggest that cephalospore in first generation, second generation, even third generation, short course, 5 days may be used. It's not correct. It's not necessary. We don't have to hit a mosquito with a Sten gun. Tap like mosquito would get killed. So you can use amoxicillin rather than any of these drugs. An amoxiclav is not required because streptococcus don't produce beta lactamase. So you don't have to, they are not resistant to penicillin or amoxicillin. Case 2. This is a 3-year-old, fever for 3 days, has been afebrile from day 4, has mild rhinorrhea. The mother said, doctor, the rhinitis is a little bit worrying me because it has become mildly yellow. And the X-ray is taken. The X-ray shows opacification of maxillary sinuses, reported as maxillary sinusitis, bilateral. And the young pediatrician advises cefodoxime for 5 days. Is that right? Let us try to audit. Look at this young child, 2 years old, picture taken from my OPD. This pus pouring out from the nostrils. This, if a child has got fever, toxemia, or if the duration is long, then it is a clinical diagnosis of bacterial rhinosinusitis, which I would like to call it as ABRS. You don't have to do any tests. I remember a mnemonic called PWS, which I have taken from the New England Journal of Medicine. You can clinically diagnose acute bacterial sinusitis using this mnemonic. What is that mnemonic? Very simple to remember. PWS. What is P? Persistent symptom. Look here. Look here. Nasal congestion, rhinorrhea, cough more than 10 days, 10 or more days without improvement, irrespective of the quality of discharge. Child is having 10-day symptom. It's not a known case of allergic rhinitis. Yes, it is acute bacterial sinusitis. You don't have to do any test. Fever need not be there. Second is worsening symptoms. Biphasic illness like dengue. Child has got fever for 2-3 days. Tends to get better. But then from day 5-6, again there is fever. With increase in rhinorrhea, the cough becomes worse. Biphasic. That also indicates there is a strong possibility of acute bacterial sinusitis. The third group is not very commonly seen in young children, maybe seen in adolescents. High fever, 3 to 4 days, severe tenderness over the maxillary area, purulent rhinorrhea like the one I just now showed you. Only 2 days fever this girl had. But that was classic sinusitis. She was toxic. So severe symptom. If you remember the PWS mnemonic, there is no need for any investigation. Counts don't help, CRP don't help. X-ray is useless, absolutely useless, unnecessary radiation. CT scan, often misused, is not required. CT scan should be done only if you are considering surgery or if the child has got complications like periorbital cellulitis. Coming to choice of antibiotics, we should apply the simple rule like McKesson score. Amoxicillin is good enough. But if somebody has received antibiotic in the last 1 month, then you can consider second line amoxiclav or maybe cefodoxime. In the duration, somehow we pediatricians, we are very fond of writing drugs for 5 days. I don't know why this 5-day rule. Anything and everything, 5 days prescription, which is wrong. But for sore throat, 10 days, sinusitis, 7 to 10 days, or at least minimum of 7 days, not 5 days, 3 days, 5 days, sinusitis therapy, no. And we should reserve seating only for complicated. And if you have a child who has very severe symptoms with toxemia, acutely ill child, you think that the complication, ceftriaxone can be given, but I have rarely given ceftriaxone for sinusitis. What is imperfect? What is the imperfect choice with regard to antibiotics? Azithromycin for sinusitis, I'm afraid is not correct. Cefixime, cefpodoxime, clindamycin upfront, no. Relying on X-ray diagnosis, no. And anybody who has got mucopurulent discharge, you cannot give antibiotic. The reason is very simple. Child with allergic rhinitis may have mucoid or even mucopurulent discharge if there is secondary viral infection. Just because there is purulent discharge, it doesn't mean it is bacterial. Just because there is no purulent discharge, it doesn't mean it is only viral or allergic. So anything can occur. It's duration which is important. And of course, it is wrong to prescribe antibiotics for 3 to 5 days in sinusitis. Case number 3. As seen in the X-ray, this is a child with pneumonia. 2-year-old, fever, cough, tachypnea. Total count 20,000. Taking feeds well, not toxic. X-ray is taken. As you see here, you get a lobar consolidation here, the upper zone, most probably in the upper lobe. And somebody prescribes IM ceftriaxone, please come and take for 7 days. Is that right? Let us audit this. Again, amoxicillin will work wonders for most pneumonias because pneumococcus in India, fortunately in the respiratory tract, are exclusively sensitive to amoxicillin. 40 mg per day is enough. OP treatment for somebody who, even if there is high count, even if there is consolidation, taking not toxic oral antibiotic is good enough. No X-ray is required. And if a child has got conjunctivitis and there is a lobar consolidation, we should give amoxiclav. What is the reason? It could be H flu. It should be H flu, which will not respond to amoxicillin because H flu is a beta-lactamase producing organism, unlike streptococcus. And then we all know we should avoid antibiotics for viral LRI, more relevant in the days of COVID-19. Coming to the imperfect choice, azithromycin upfront for all pneumonias, not acceptable. Amoxiclav instead of amoxicillin, not necessary for pneumonia without retractions, pneumonia which is not severe. Oral cephalosporins, first generation, don't do anything for pneumonia. If at all you use cephalosporin, you have to use cefpodoxime or cefdinir. Clindamycin is not a good drug for pneumonias. It's a bacteriostatic drug. It has got only a gram-positive spectrum. So unless it is Borsa or methicillin sensitive staph aureus, or if you suspect anaerobes, clindamycin need not be used. And repeating X-ray after 1 week, just to tell the parent that it has resolved, it's foolish. For the simple reason, the X-ray consolidation may remain for 1 month, child could be better in 1 week. And ceftriaxone for all community-acquired pneumonia is not required. So you can treat with amoxicillin alone. Let us move to case number 4. This is an adolescent with pneumonia, 12-year-old, fever and cough for 5 days, fever 101, child is tachypneic, saturation is okay, total count is 4,800, hemoglobin is 10, somebody has done mycoplasma IgM, azithromycin is prescribed, and you see here lobar consolidation in the right lower zone, most probably the Silhouette sign is there. Okay, the right cardiac water is not clearly seen. And this, somebody would say that this is atypical pneumonia. Why you would say it's atypical pneumonia? First thing is an older child. Second thing is that the child is not very toxic. Third thing, counts are not high. Fourth thing, mycoplasma IgM is. So are you right in prescribing azithromycin? That's the question. But in a child like this, Studies have shown it's enough if we give coverage for pneumococcus rather than coverage for atypical pneumonia. But if you are sure of diagnosis of atypical pneumonia, somebody very non-toxic, older child, then azithromycin or doxycycline may be good enough. Of course, recent literature has suggested that most mycoplasma in China, maybe in Western countries, even in India, are resistant to both azithromycin and doxycycline. The child doesn't improve, levofloxacin can be considered, but I would give it only in an older child, not in a young child, because it's a very precious drug which is used for MDR TB. Only azithromycin for these children is probably not rational, particularly the child is below 5 years of age. The reason is bacteremic pneumonia will not respond well to azithromycin. If at all you want to give azithromycin, it should be in addition to beta-lactam. And studies have shown that IgM mycoplasma. In fact, we have done our own study in our hospital where normal children, pre-operative, about 14% of them have IgM positivity, whereas in pneumonia, we got only 22% positivity. It's not a very reliable test. PCR, again, PCR may be positive, but mycoplasma may not be the cause. But recent search and literature suggests that if you have somebody who's symptomatic, severely symptomatic, and if PCR is positive, there may be benefit of giving specific therapy with azithromycin or doxycycline. In our own unit, to curtail azithromycin, we prefer to give doxycycline for the simple reason that we have a lot of scrub typhus presenting with pneumonia. So we do not use azithromycin routinely, we use doxycycline. Coming to the other imperfect choice is azithromycin, somebody who's got cough and wheeze. That's not rational at all. Some literature had emerged that children who get recurrent wheezing, viral associated wheezing, or multi-trigger wheezing, short course azithromycin decreases the duration of illness. And it's not necessary. We'll end up only giving too much of azithromycin and end up producing resistance. But recently a paper has been published in South Africa where they gave azithromycin to all children under 5 every 6 months. And I believe it reduced the under 5 mortality. That's one of the papers which has been published in New England Journal of Medicine, but too little data is available to practice that routinely. Case 5. This is an infant with CNS infection, hospital-based scenario. 8-month-old has fever and vomiting for 2 days, followed briefly by seizures. Child is looking sick, febrile, and irritable. The anterior fontanel is full. Clinically, it is probably acute bacterial meningitis. So what do you do for this child? Because you have taken blood counts, total counts are high. 2000 WBCs, mostly polymorphs. Glucose is low. Gram stain, no organism. Started on ceftriaxone. Is that right? Let us ask ourselves. In a child with a suspected bacterial meningitis, what is perfect and what is imperfect? Today in 2020, if somebody with this CSF finding, with this clinical finding, suggestive acute bacterial meningitis, 2000 cells in the CSF, whether the child is vaccinated against pneumococcus or not, a combination initially empirical choice of ceftriaxone and vancomycin is justified. You must all be wondering, the last 4 scenarios I have been very conservative. I've been telling that we use the least spectrum antibiotic. But here I am saying you use big guns. Very simple. One, any CNS infection is dangerous and you have to hit hard. You have to escalate. It is not impetigo. It is not sinusitis, which is non-life threatening. It is not bacterial tonsillitis. They are all going to give you time. Even enteric fever will give you time. But bacterial meningitis, if it's going to be caused by a resistant organism, you have to use upfront the second line antibiotic. When do you use that? What is the scientific basis for this? Microbiologists have said that in any serious infection like CNS infection or endocarditis, If your community incidence of resistance to the first line exceeds more than 10%, microbiology suggests in such serious life-threatening infections, you have to add a second line drug. This is what has been recommended by the American Academy of Pediatrics quite a few years back. But in India, they have not been practicing. But then there is evidence today. I'll talk about it in the next slide. So in India, in CMC Vellore, there is a beautiful publication which came in 2017, which showed that nearly 40% of meningeal isolates using the new guidelines for penicillin and ceftriaxone resistance or cefotaxime resistance, the incidence is they are resistant to penicillin and cefotaxime in about 40% of isolates. These isolates are not from CMC Vellore alone. It's an all India based data, but they all were analyzed in CMC Vellore. So if somebody says it's in Vellore, in my state, it may not be. I think that's not correct. It is an all India representation of resistance. So, as I said earlier, you must hit hard. Today, if you have a diagnosis of acute bacterial meningitis, you must cover drug-resistant pneumococcus and give vancomycin. Of course, if you get penicillin sensitivity, then you can use penicillin or ceftriaxone, stop vancomycin. And most importantly, what is often not done, the moment you diagnose acute bacterial meningitis, you should not give 25 milligram per kg or 50 milligram per kg of ceftriaxone. You should give bolus dose of 100 milligram per kg to immediately try to kill the organisms. And if you find resistant bug, you have to repeat the lumbar puncture. That is. And in older children, there is no rationale in using piperacillin tazobactam for meningitis. It's got very poor CNS penetration. For pneumococcus, which is the most common organism, piperacillin tazobactam is not required. Okay. And more importantly, somebody with febrile seizures without doing lumbar puncture, unless it is contraindicated, you should not be giving antibiotic before doing lumbar puncture. Even one dose of even an oral antibiotic will prevent pneumococcus from being identified. Only now we are getting isolates of pneumococcus in our own institutes with great difficulty because we have improved our microbiology techniques. And we have also standardized the procedure for giving antibiotics only after LP. Coming to the next scenario, fever without focus. This is a 6-month-old infant who had fever for 2 days. No focus is obvious. Temperature 102. Obviously, parents are worried. The pediatrician is also worried. We asked for a total count and differential count, 14,200. Polymorphs are 78, lymphocytes 22, CRP is 24, and the pediatrician starts on cefixime. He feels because of the CRP being 24, total count being 14,000, polymorph predominant, he thinks it could be a bacterial infection. Is that right? Let us audit this. We must remember in a scenario like this, 6 months old infant, fever without focus, it is not meningitis which is the commonest cause. It is not accal bacteremia, what is described in textbooks, which is the commonest cause. It is UTI which is the commonest cause. That is often forgotten. There is no point in starting antibiotics without at least a urine routine, if not a urine culture. And CRP and procalcitonin have very limited value. Now all of us know in COVID, CRP has come back to the bang. The moment you see a CRP of 100, our blood pressures go up and the child's blood pressure comes down. Procalcitonin is causing a lot of confusion even in COVID-19. It's not very useful in COVID-19, nor it is useful in infant with fever without focus. Extreme leukocytosis. The moment, what is extreme leukocytosis? If you have anybody in whom you have done a blood count, the total count is 25,000. It's an alarming lab finding, more important than CRP or procalcitonin. This is called extreme leukocytosis. And if you have extreme leukocytosis, studies have shown nearly 20% have pneumonia. Even if the child is not having tachypnea, you are justified in asking for an X-ray because occult pneumonia, pneumococcal pneumonia is a notorious cause for extreme leukocytosis. And UTI, well-known acute pyelonephritis, can cause leukocytosis. Of course, you can get leukocytosis in osteomyelitis, meningitis, anything which is causing pus anywhere in the body. Giving cefixime for all high fevers without focus is irrational. Forgetting UTI as a possibility is irrational. Giving IM ceftriaxone for somebody who's got fever without focus is not correct. And of course, not doing urinalysis. 17% of all young infants below 3 years of age who present with fever without localizing signs, they have been proven to have UTI. Even if the urinalysis is normal, probably you are justified in doing a urine culture in fever without localizing signs below the age of 3 years, more so in infants. Coming to the use of antibiotics, if in case you do a culture and you get a culture positivity, then you will have to decide on the correct choice of antibiotics. But let us see what is perfect. OP, cefixime or amoxiclav after culturing is fair enough. If the urine shows plenty of pus cells, child is symptomatic, you need not wait for the cultures. You can send for culture, and then start on antibiotic. And amikacin, perhaps this is the only parenteral antibiotic which you can give in practice in case there is a high probability of ESBL UTI. For example, if the child has had recurrent UTI and you have done a culture, you want to treat it as OP. If you are sure the renal function is clinically okay, you can give IM amikacin as monotherapy. Ceftriaxone or piperacillin tazobactam, depending on your ESBL prevalence. In our own hospital, nearly about 70% of all organisms are resistant to ceftriaxone and cefixime. Nitrofurantoin, norfloxacin for any child with urinary infection with fever, particularly below the age of 5 years, is irrational. The reason is they are locally acting drugs. In a child with pyelonephritis, you want to achieve blood concentrations, you want to have antibacteriemic action, you want to sterilize the urine fast. So you must use a drug which has adequate serum and renal concentrations. Nitrofurantoin and norfloxacin, they should not be used for febrile UTI in pediatrics. In an asymptomatic bacteriuria, repeat culture, child is asymptomatic, you shouldn't give antibiotics at all. You will never be able to eradicate the organism. Doing a culture in the bag, urine bag, and then starting antibiotic, highly irrational. I know the mother has to be a good wicket keeper like Dhoni to catch the urine. But then if you can't, please catheterize because it's going to be crucial for diagnosis. Send them to an emergency room. Ask them to give a lot of water and food, catheterize, then start antibiotic. Never collect back culture for diagnosis. And of course, you must know how to interpret colony counts and the significance. And then recent data has emerged in such a fashion that to get prophylaxis for anybody who has developed first UTI, everybody, 100%, that's not correct. Less and less uroprophylaxis is being recommended now, but that's beyond the scope of this lecture. And our own data, which we had, I wanted to share with you. We, in our series of cases, we found the ESBL isolates were very high. Nearly 40% of our isolates of E. coli, Klebsiella proteus were resistant to ESBL. But amongst them, many of them responded to ceftriaxone. We didn't change. We had failures only in about 40%. But recent data has come in such a fashion, but if you grow ESBL, even if your patient is responding to cephalosporin, the child may relapse. So you may have to think of alternative antibiotics like amoxiclav, cotrimoxazole, piperacillin tazobactam, or even meropenem in bacteremic children. And we try to identify what are the risk factors, and we published this, and we could not identify any specific risk factors to predict ESBL. But I can tell you ESBL is on the rise. So using quinolones routinely for UTI is not the right step. Maybe consideration to use amoxiclav as first line may be preferable to cefixime. Seventh case. This is a neonate with fever. This is 9 days old, abdominal distension, poor feeding, temperature 38, hospitalized, counts CRP, blood cultures, LP done, and somebody starts on ampigenta. So this is 9 days old. What looks like neonatal sepsis. The pediatrician has done everything correctly, but he has started on ampigenta. Is that right? Let us audit this prescription. One of the commonest things that happens in neonatology is that giving antibiotics without blood cultures. This is one thing that is happening everywhere. That should not happen. There is no newborn should ever get an antibiotic without blood, urine, and CSF cultures. Piperacillin tazobactam or meropenem with or without amikacin. I'm sorry, today's antibiogram in India suggests that you have to necessarily give either a beta-lactam inhibitor combination like piperacillin tazobactam or a carbapenem with or without aminoglycoside if you have neonatal sepsis early or late. I'll come to it later. And of course, if you grow something and if it is sensitive to ampicillin genta, you can de-escalate or even cefotaxime. And of course, we have to follow the rules. In neonatal sepsis, we have to follow the rules. The IAP neonatology chapter suggests that minimum, there are some rules for giving antibiotics. Minimum 7 days is what they recommend in culture negative sepsis. Even that is being debated now. Treating CRP values with meropenem and colistin is not correct. There is no role for oral antibiotic therapy except in the rarest of rare instances like mild umbilical sepsis, follow-up for osteomyelitis. Absolutely no indication for oral antibiotics either for meningitis or sepsis routinely. And antibiotic prophylaxis like antifungal prophylaxis in newborn has not taken off, fortunately. Coming to some startling data which I'm going to share with you. Look at this data which has come in JAMA network, open 2020. What does it show? They have analyzed the coverage of 3 antibiotic regimens for neonatal sepsis in the hospital setting across Asian countries, which includes Cambodia, China, India, Indonesia, Nepal, Pakistan, etc. They have come out with startling findings. What are the findings? You see here, India, I'm sorry, this slide is not too good. You see here, in India, only around 7% of the isolates are sensitive to carbapenem. That's worrying. The remaining probably are sensitive only to colistin. So 1/3 of our isolates in India, in newborn, may not respond to carbapenem. And more importantly, look at the coverage for 3rd generation cephalosporin. Only 30% of isolates in India are covered by your 3rd generation cephalosporin. Around 43% only are covered by ampicillin and gentamicin. So where does that take you? I think in India, both early onset neonatal sepsis and late onset neonatal sepsis have got the same flora. Unlike the West, where they report group B streptococcus and listeria, we don't have that. It is Klebsiella, E. coli, Acinetobacter, and Pseudomonas, and maybe Staph aureus, MRSA. So, ampicillin gentamicin is being discredited. It's more a placebo. But of course, somebody might say, in my nursery, I find the 80%, 90% of the isolates are sensitive to ampicillin gentamicin. He is right. But I can tell you, most Indian data suggests that ampicillin gentamicin has no place. Cephalosporins are equally bad. We have to necessarily, if there is a proven sepsis or strongly suspected sepsis, we have to go in for BL, BLI or carbapenem used with or without amino acid. See here one more article in BMJ 2019. Same Indian data. Nearly, look at Klebsiella, ampicillin, gentamicin, all resistance is around 75 to 85%. Cefataxin 72.5%. Only meropenem, only 10.4%. Similar in E. coli, same figures, Acinetobacter, Staph aureus. So the story is the same. So nobody can say we don't have data. We have enough data that our neonatology spectrum of resistance is very, very dangerous. We can't be using Ampigenta alone. Proven sepsis, unless you have proof microbiologically, there is no point in starting Ampigenta. Again, some more data, again published in Lancet, same story. So resistance rates are very high. So the moral of the story is, in neonatal sepsis, place for prophylactic antibiotic routinely. Please decide your antibiotics based on your own local epidemiological data, microbiological data. But there are some centers which use quinolones with success. If you have data, fine. But our own hospital, I can tell you, our ESBL rates in newborn sepsis is around 80%. So we do not use, I don't remember using cefataxime at all in newborn, except in the rarest case where we have seen whether I was asked to give an opinion, meningitis, we de-escalated from meropenem to cefataxime. That happens very rarely in our setup. But there may be other centers which have different experience. But my suggestion is this is to be seriously considered. Day is not far off when the situation might change. Case number 8, infant with acute watery diarrhea. Some dehydration is there. Temperature is 100. Counts are done normal. Stool 12 pus cells. Day 1, somebody starts cefixime. Day 2, day 3, the child is still having diarrhea, amikacin, ofloxacin, metronidazole. Let us audit this. What is perfect in acute watery diarrhea? Zinc ORS diet alone. Antibiotics for dysentery. Dysentery means there is no need to do stool routine. If you see visible blood, it has been correlated with a lot of assurance with Shigella. So Shigella has to be treated. It has to be prevented from spreading to others. Antibiotics are indicated. Somebody has SAM, sepsis, cholera, you are going to give antibiotics. So giving Gil combos, I call them Gil combos. All those nidazole with quinolone or cefixime, should not be used. Amikacin should not be used because amikacin does not have any act against Shigella or Salmonella, but they are all organisms which are intracellular. No amikacin or gentamicin. No ceftriaxone for acute watery diarrhea. And again, antibiotics for transitional stools, poor milk diarrhea in these days of breastfeeding week should not be given at all. Case 9, my last case, fever for 5 days, 5-year-old, 5th day, the fever is not coming down, increasing trend, spleen is tipped, young pediatrician labels this as enteric fever, asks for only CBC, Vidal, urine routine and culture, does not ask for blood culture, and he wants to make sure the child gets better early. So he wants to prescribe ofloxacin and azithromycin. Is he right? Let us audit this. When it comes to enteric fever, culture should be done. I'm sure many forums you would have ad nauseum heard this. The culture of culturing should improve. Even today it happens. It's very simple. When we have CT, MRI, blood culture, so many labs are around. One sample you can take before giving antibiotic if you have a diagnosis of enteric fever. And if you give even one dose of antibiotic, your yield is going to come down. Even in the best of centers, the yield from blood culture will be 70%. And only single drug should be used. You can use cefixime or azithromycin. Recently, we have evidence of cotrimoxazole. And you should not stop the habit of stopping antibiotic. For example, day 5, the same child, you have done a culture. Next morning, you give 1 dose of cefixime. Next morning, child becomes afebrile. 48 hours later, culture is not growing anything. I don't think we should continue cefixime just because we have made a clinical diagnosis of enteric fever. You should be bold enough to stop. Then antibiotics for enteric fever, if it is azithromycin, you give only for 7 days. If it is cefixime or quinolone, it is always 14 days. Ceftriaxone should be given only for hospitalized and toxic. IM should not be given, it is painful. Using quinolones is not appropriate today. Nalgesic acid resistance, ofloxacin resistance is very high, ciprofloxacin resistance is very high, failure rates are very high. There is no place for dual therapy. And changing drug without sensitivity reports is not correct. Treating Vidal or the new typhoid test is not correct. And of course, when you have everything looking like typhoid, culture is negative, we should not miss typhus. You should always consider adding doxycycline. Using cefixime in a dose of 8 to 10 milligram, what we use for dysentery is not correct. Again, azithromycin is 20 mg per kg. All of you know that very well. Here, I would like to share our own experience. About 15 years back, there were different protocols in our own hospital for typhoid fever. In our own unit, we are using one drug. Some physicians prefer to use 2 drugs. So we thought we will compare what happens if we give 1 drug or 2 drugs. Look at this. The duration of fever was not different in either 13.54 versus 13.84. And deferescence did not change. It was 5.24 in single drug, and it was 4.32 in 2 drugs. This is not statistically different. So we said that single drug is good enough. And this is being quoted even in the JAPI Journal of the Physicians. And they also recommend only single drug. All of you would have heard some reports have come from Nepal suggesting 2 drugs. We have not reached the drug. We have not reached the stage. So let us stick to only 1 drug. And the drug shouldn't be allowed to act unless the child is very sick in septic shock. There is no need to change the antibiotic. The child is only having fever and not having toxemia. The fever persists, we have to look for other causes other than enteric fever per se. And I would end my session with some food for thought. Because I can't put an audience poll in the webinar. I don't know. I don't have that much technology. And I'm not conversant with all these voting pads and all using the webinar. Suppose I ask you, is prescribing antibiotics unnecessary in majority of instances in private practice? If I put to vote, I am sure maybe in Kerala, pediatricians, the physicians, the general practitioners are very disciplined. If I ask this question on an all India basis, the answer would certainly be yes. Then I always wonder what are the reasons. And I realize the reasons are many. Some are due to factors which we can control, some are due to factors which we cannot control. Basically, for the parents, fever means bacterial. That's a concept. For that matter, most doctors also think that once there is fever, it's likely to be bacterial, don't take a chance, give an antibiotic. Parents put pressure on us. If it is going to be an MLA's child with even 1 day fever, my friends will say, I don't want to take a chance, I will give an antibiotic. Or parents are working, they can't take leave, IT professionals, they'll put pressure, doctor, why not you give an antibiotic? And we always have the fear of losing the client. If I don't prescribe antibiotic, parents are not going to be happy, they're not going to come back to me. Fear of secondary infection. Studies have shown the risk of secondary infection following viral URI is hardly to the tune of 5%. So the remaining 95% should not be given antibiotics. That fear is there lurking, even in COVID-19. Okay, there is always fear of secondary infection. Studies have, even in COVID-19, have shown the risk of bacterial infection in children is very, very small. Lack of time to think. Okay, if you want to analyze whether it's bacterial, viral, take proper history, family history, past history, severity of symptom, it will take at least 5 to 10 minutes. So if somebody wants to see 100 patients per day, They know time. Instead of that, you can easily prescribe an antibiotic, not worry about your time. Saturday evenings are dangerous. Not available on Sunday. The patient will say, doctor, you won't be available tomorrow. Please do something. So we are always pressurized to prescribe an antibiotic. And of course, pressure from pharma industry. They are our friends. They do their job. He will come and say, the representative close to you will come and say, sir, in the neighboring pharmacy, this has so many bottles of cefixime or cefixime metronidazole, cefixime oronidazole, cefixime ofloxacin. They are not being sold. Why didn't you clear them? Okay. So he puts pressure on you. He puts pressure on you by quoting literature in 1960, saying that cefixime is good enough for pharyngitis, fever, fever, typhoid, toxemia. Lack of confidence. If you don't prescribe antibiotic, you won't pick up practice. Nobody told you. The youngsters are not told. If you are not prescribing antibiotics, you will succeed. I still remember when I finished my house agency, I was advised to injection terramycin, old tetracycline, for all patients with fever. That was the advice given by my friends in the Department of Medicine. And other reasons are sheer economics. You know, all of us know that due to COVID-19, pediatrics is facing recession. In peer pressure, if I don't prescribe, somebody else will prescribe. Playing safe and feeling secure. Oh, we have given antibiotic. We don't have many role models like Amdekar, Paniraman, etc. And in medical curriculum, you can get a pass without knowing the dose of insulin if you know the gene locus of Wilson's disease. And we don't think there is a need to save antibiotics. And finally, we all think that the Western concept of antimicrobial stewardship is not relevant. Ours is rural practice. Past bitter experience, like I call it house agent syndrome. One case you would have seen, fever without localizing sign turning out to be meningitis. Oh, antibiotic could have saved this child. No. There are some people who, in spite of sermons and discourses, they think that you can't but prescribe antibiotics. Past success. My professor used to say, even if a chimpanzee sits in the evening clinic with the red light on, but the chimpanzee doesn't bite customers and starts prescribing antibiotics, chimpanzee will have a roaring practice as long as it doesn't bite. So anybody can succeed prescribing antibiotics, but patients are most children have viral infection. They are going to get better with or without antibiotic. And we always think it is impractical to withhold antibiotics. It's not possible. And finally, happiness quotient. At the end of every visit to a clinic, the parents want a prescription for you. They don't want a sermon from you. They are happy to receive a drug rather than counseling. And parents think that every visit should be followed by a prescription. What do you think we should do? Very simple. We should urge our friends to use antibiotics sparingly. In this picture from a publication, Indian Express, you see Paniraman sitting here. Me and Paniraman, we have conducted around 20 programs called Prop Me, Practicing National Office Pediatrics, Made Easy. We created a module with a 4-hour session covering fever, cold, cough, diarrhea, and we tried to pass on the good message of appropriate usage of antibiotics in Tamil Nadu. And what we have done at the hospital, we have an antibiotic policy. We review it every 2 hours, and we conduct a workshop for all our PGs, what is called APME, antibiotic prescribing made easy, where with an 8-hour session, we orient themselves to rational antibiotic prescribing. At the end, I would say that choosing antibiotics, it needs only a will to practice rational pediatrics. It requires patience and time. All you have is a good mindset. If you follow these principles, and with the case scenarios which I have given, I am sure you will not agree. Rational perspective is very possible. Thank you very much. If there is any feedback, you can send a mail to me. Thank you very much.
Thank you. Thanks a lot, Dr. dear Bala sir for that amazing experience taking us through the antibiotic choices, the dilemmas, of course, clinical version of the antimicrobial stewardship with clinical case scenarios. I believe the bottom line was the possible reasons why, in spite of learning and knowing more about antibiotics and of course, having a good insight into the appropriate antibiotics, many a time it is quite challenging not to prescribe antibiotic. It's rather not easily done prescribing an antibiotic than it's more difficult not to prescribe. And of course, the parents, as you said, they don't want a sermon, they want a prescription. Sir, you have taken us through right from the respiratory choice of antibiotics in the throat infection, so-called throat infection, through the meningitis, then the dysentery, the newborn infections, and I believe almost all the clinical settings have been covered by a prototype case scenario. Well, sir, you got quite a good number of questions from on the platform, and we have got some stalwarts also here. I'm thankful to Dr. Shami Ghosh for answering from Calcutta, for answering a good number of questions on his own, but they've been quite useful on the forum. And Dr. Ashwin is also there from Shimla, the ID experts. One thing which just captured the attention of the floor is where the CF penetration of vancomycin. A lot of discussions have been going on there, whether it's really theoretically, as you have said, subtraction of vanco in acute bacterial meningitis, how far is the penetration of vanco and how it is best described?
Extremely good question, relevant question. When compared to third generation cephalosporins or any fourth or fifth generation cephalosporin, the CSF penetration of vancomycin is inferior. But like most antibiotics, when the meninges are inflamed, the penetration is better. For example, if you give penicillin to a normal individual or even third generation cephalosporin to a normal individual, CSF penetration may not be as good as desired. But if the meninges are inflamed, the penetration is better. That holds good for vancomycin. Only because of concern of penetration, even if your lab suggests that there is lack of sensitivity with high MIC with ceftriaxone or penicillin, you should continue both ceftriaxone and vancomycin if there is a drug-resistant pneumococcus identified. In fact, treatment of those who have been given only vancomycin, they do worse when compared to those given dual therapy.
Well, sir, and I believe the message is clearly conveyed. In an inflamed meninges, the penetration of vancomycin is quite good, as well as even in ceftriaxone.
Sir,
Anything else, sir?
One more important thing, most centers, most ID consultants today world over, they recommend tough monitoring of vancomycin in serious infections like sepsis or meningitis. Most centers do that. And it is recommended to do in high-risk situations like meningitis in intensive care units today.
Sir, sir, I want to ask a practical question. Most of the children with infections are coming with a low dose of antibiotic from periphery or some other hospitals with a low dose of antibiotics. Whether it is justifiable to give that upgrading to the normal dose, or should we start another antibiotic?
Extremely good question. See, we have, I always believe we have two problems. One is starting trouble, another is stopping trouble. Okay. I'll first talk about stopping trouble. See, it happens to me also. It's a very good question you ask. For example, a child will come to me on day 3, fever. A pediatrician would have started amoxiclav on day 2, and he'll also be your friend. And the patient will come to you, fever has not come down, and you know the whole thing is viral, and you have to be very diplomatic. You know what I tell them? I tell the parents, Ma, when the doctor saw you yesterday, he felt that drug was necessary, but today I don't think it is necessary. Even if that doctor sees today, he may tell you to stop the drug. So we will stop. That is not wrong. Whatever he did at that time was okay. Now we will stop and see. So that is my way of conveying to the patient that it is not necessary. At the same time, not insulting the other doctor, not trying to please the patient by saying the other doctor was wrong and I'm right. So I tell them, "Ma, at this point of time, it does not look like bacterial infection. We can stop. If you are convinced there is no indication for antibiotic at that point of time, I think you should be bold enough to stop, be diplomatic enough to see that the other doctor's image is not spoiled, and your personal relation. Ethically, it is not correct to criticize the other doctor. Parents might say, "Doctor, that doctor always gives antibiotic." I always tell them, "Don't talk about it, ma. Now you tell me." On the other hand, the reverse happens. When my patient goes outside, some of my students practicing in periphery will say, "Are you a SBSR patient? I won't give antibiotic." Won't you give antibiotic? The child has got osteomyelitis or meningitis. You will give, whosoever is the patient. So the moral of the story is, we are not saying don't give antibiotic. Give antibiotics appropriately. For somebody with meningitis, hit hard. Where it is indicated, give the right antibiotic at the right time, right dose, right duration, and right routes.
Sir, your answer is up to the point. But my concern is whether for a bacterial infection, one of our colleagues started a low dose of drug. Should we continue the same drug in adequate dose, or whether we should have to give another antibiotic?
Sir, for example, in enteric fever.
Yeah.
It is clinical judgment. I'll just give you an example. You take somebody who has got acute bacterial pharyngitis. Okay. Somebody has started mosquito dose of amoxicillin 20 mg per kg.
Okay.
They come to you. You are convinced it is bacterial. You should give the correct dose of 50 mg. On the other hand, if you are convinced it is not bacterial, stop it.
So same drug we can increase the or adequate dose you can give.
Absolutely, absolutely. It is your judgment, your decision, based on the patient's findings and your assessment and labs if necessary.
And that can be taken as day one when you start to escalate the dose.
Preferably, yes. Preferably, yes. Yes. Yes.
Thank you, sir. Thank you, sir.
Dr. Sulfi, that was a very interesting question.
Yeah.
Because even I was wondering, especially enteric fever, Cedixin, lower dose is started, and then you would like to escalate the dose when you realize that it is enteric fever and not adequate doses are not given.
Sometimes if you read literature, you'll be wondering how these 3, 5, 7, 10, 14, 21 have all been arrived at. They would have all been arrived at with meetings similar to what Ramesh conducts in so many consultative meetings. The number of days would have been decided over tea breaks. Okay. All this is empirical. Between 9 and 10, there is not going to be a big difference. 6 and 7, there is not going to be a big difference. But the point that you must remember is what is called target achievement. In case you have somebody who has a serious infection, like for example, meningitis or brain abscess, right? Or septic arthritis, you have to use a drug for a longer time. On the other hand, if you have trivial infection, impetigo is not going to kill a child. A small abscess is not going to kill a child. So shorter duration is recommended. Longer the duration when your target achievement rate is high. When your target, in fact, impetigo, even if you don't give antibiotic, it can get cured. The person's immune system is okay. So you can give short duration and a smaller antibiotic. But severe infections, you have to have a drug which is above the MIC constantly. That is one of the reasons why I mentioned ceftriaxone has to be given 100 milligram per kg bolus. And has to be given BD, not OD. Similarly, if you want to give vancomycin, it has to be given 6 hourly if it is meningitis. You must monitor the drug level.
Sir, I think that was very well conveyed. Dr. Nandakumar, the Kannur Warrior, as well as your MMC product, he would like to know from what age group can be prescribed doxycycline in children? Many times debated, but we want to answer from you.
Newborn onwards. See, you shouldn't be worried about staining of the teeth as long as you are able to save the life of the child. There are case reports of neonatal typhus. The drug of choice is doxycycline. Doxycycline is a very, very safe drug. Okay. The moment you think of scrub typhus, if there is an indication, you can use even in newborn. Absolutely no question at all. What if the teeth get stained? A good dental surgeon will take care later. Safe. Doxycycline is one of the safest drugs. As far as side effects are concerned, allergy is concerned. You can use. In fact, if you give doxycycline, the fever doesn't come down in 48 hours, you have to revise the diagnosis. Empirical doxycycline, yes, very, very rational, appropriate, indicated.
That was clearly taken, sir. We have got Dr. Ravi Sharma putting it across like, again, Dr. Nandakumar, does in the community acquired pneumonia setting mycoplasma, does clarithromycin has any advantage over azithromycin?
Extremely good question. I think clarithromycin versus azithromycin, two things have emerged. One, in terms of utility in mycoplasma, there is no difference between the two. Conventionally, azithromycin, because it is, you have to give for shorter duration, OD dosage, it has been preferred. So we have been using it. If somebody wants to give a clarithromycin instead of azithromycin, 7.5 milligram per kg, BD, 7 to 14 days for mycoplasma, it is not wrong. The spectrum for pertussis, spectrum for mycoplasma is similar. Against H influenza, if there are sensitive strains, clarithromycin may be superior to azithromycin. It's the only difference. Traditionally, we are used to giving azithromycin. Somebody gives clarithromycin, it is not wrong.
Clear, sir. Dr. Ravi Sharma has
One
mentioned,
point
Dr.
is azithromycin has been proven to have more anti-inflammatory activity than clarithromycin. So, in fact, bronchiolitis obliterans, chronic lung disease, cystic fibrosis, all these conditions, azithromycin has definite advantage over clarithromycin.
So do you see any more incidents for resistance to azithromycin than clarithromycin?
I don't have
It's widely being misused, azithromycin. So anything like?
I have not looked at data. It's a good question. I'll have to read and tell you. I'm unable to answer that about clarithromycin resistance versus azithromycin resistance. But I can tell you, in China, one study has quoted more than 90% of strains of mycoplasma are resistant to azithromycin, and nearly about 70 to 80% are resistant to doxycycline also, tetracycline also. So you will be forced and tempted to use levofloxacin for mycoplasma.
Dr. Ramesh?
Okay, sir. Yes.
Dr. Ramesh, can I ask a question?
Yes, sir. Please, sir.
Sir, as the influenza meningitis has decreased in incidence, is there any role of steroids after the age of 3 months in a case of acute bacterial meningitis?
Extremely good question. One, few points must be remembered. If you look at the history of steroid use in bacterial meningitis, few points have emerged. One is that steroids reduce the incidence of sensory neural deafness in H influenza meningitis. Two, steroids might decrease the mortality in pneumococcal and H influenza meningitis. Three, most of the beneficial effects of steroids in meningitis have been based on data with H influenza. Four, in practice, it's very difficult to get a case where the child has not received an antibiotic. For example, there is no data on children because it doesn't happen in US. US, nobody gives antibiotic if this meningitis is suspected. Here, many patients will come to you after they receive 1 dose of IM ceftriaxone or cefotaxime. Studies have shown the benefits are best if you give steroid before giving antibiotics. After giving antibiotics, I believe steroids are not very effective. So antibiotic naive cases, pneumococcal H flu meningitis, dexamethasone 0.15 milligram per kg, 6 hourly for 2 days, has been known to reduce morbidity and mortality. So preferable to give before giving the first dose of antibiotic. Very difficult. I have practiced it in very few cases. I get it.
Thank you, sir, for that clear
Thank you, sir.
explanation.
Thank you, sir.
Dr. Ravidat Sharma from Amritsar was there with a lot of, I think, got most of the interesting questions and the platform discussions. And sir, about the stool examination, is there any role for routine examination and stool culture? And this has been touched from the floor.
Stool routine is never should be a routine. Stool examination, the only examination of stool is your naked eye. In fact, I tell my parents when I have difficult diarrhea cases, I ask them to parcel the stool like Saravana Bhavan Hotel, bring and show me for diagnosis. That is the best. That yield is much more than so-called stool routine examination. The next horrible thing which happens is stool reducing substance. It should not be done at all. In a baby who is breastfed, stool reducing substance will be positive 1+ or even 2+ if there is a baby who is exclusively breastfed who happens to have transition stools or 4-milk diarrhea. And even in acute watery diarrhea due to rotavirus, if you give ORS due to intestinal hurry, diarrhea, if you do reducing substance, it will be positive. You should not diagnose lactose intolerant. Lactose intolerance, again, is essentially a clinical diagnosis. Stool routine, stool pH, stool routine substance is not required. But if you suspect amoebiasis, if you suspect cryptosporidiasis in an immunodeficient child, HIV infected child, giardiasis in a malnourished child, yes, stool microscopy examination is a value. Coming to stool culture, if you want to do stool culture, you should not do a rectal swab and send it. It is useless. You should again collect directly into a culture bottle, stool examination. Perhaps if it is difficult to obtain, you can do a rectal exam, put your finger inside, the stools will come out, you can catch it for a culture. It is more required for epidemiological purposes rather than for routine. Most diarrheas don't require antibiotic, but if you suspect cholera, stool culture is better than a hanging drop. If you suspect Shigella, to identify, confirm, yes. Rarely you may get typhoid where you may get stool culture positivity, non-typhoidal salmonella. And today, we have good PCR for all these organisms. Multiplex PCR for stool. The panel is available. If you want to use it, you must use it judiciously. Maybe in selected cases who have chronic diarrhea, persistent diarrhea, and those who have immunodeficiency or underlying chronic GI problem, rather than routinely for every watery diarrhea. It's of no use. We don't do it.
So that was clear, quite well, sir. Dr. Aruru Ranganath, our infectious disease expert from Hyderabad, has asked us comments on. He said, in a case of a patient who has already been started on antibiotics, gram staining with the specimen, is it more useful than obtaining a sterile culture? Patient already on antibiotics.
Urine. Yeah, excellent. That's a very good question. It's a very good question. I think gram staining, if you're able to do in a centrifuge deposit, good sterile collection, it has as good a predictive value as colony counts. Studies have shown. But culture is the gold standard. It can be done.
Apart from urines or CSF, suppose it's a meningitis, partially treated meningitis.
Meningitis gram stain yield, yes, you need a good microbiologist to tell you. If it is positive, they inform you, it will be very, very useful. They tell you it's gram positive, you know, it's likely to be pneumococcus. They tell you it's gram negative, you know, it could be H influenza. So, or they can identify meningococcus and pneumococcus in the gram stain. It will be a great use.
But then treatment for 2 or 3 days, will it alter the gram staining
Basically,
yield?
gram stain yield depends on the number of bacilli. If somebody has received antibiotic, gram stain won't yield. Somebody has antibiotic naive, good technology, yes, gram stain is useful. Now we have biofire, we are able to, we are doing PCR for H-flu, PCR for meningo, PCR for pneumococcus and listeria, and that is more reliable. Because CSF you don't expect, unlike blood, where PCR may be false positive. CSF PCR positivity is considered a gold standard. You don't have to wait for culture reports.
But then CSF PCR positivity, especially gene expert in TBM, sensitivity is only 35%, 40%, something like.
Yeah, agreed. That's what. Even that tuberculosis, yes, but bacterial meningitis PCR sensitivity is very high. I don't know the percentage exactly. I guess it is more than 70%. If done antibiotic naive.
Fine, sir. It could be the last question. Like in neonatal meningitis, is it recommended to get repeat CSF examination after 14 days of IV therapy? That's it.
If it is penicillin sensitive, ceftriaxone sensitive, there is no need to repeat clinical judgment. In neonatal meningitis, gram negative meningitis, yes, you have to repeat. Resistant meningitis, you have to repeat. Otherwise, on clinical judgment, you can stop for pneumococcal and H influenza and even meningococcus.
Fine, sir. I think they again.
Complicated.
Yes. Fine, sir. Dr. Syed Sabik has put this safety profile of clindamycin in gram-positive infection. Is there any difference between side effects when given orally versus IV? Clindamycin.
Which drug?
Clindamycin.
Clindamycin, yeah. Oral
safety profile.
Clindamycin is a drug which is like Mohinder Amarnath, comeback drug. It came, went off, and is come back to the bang. We must understand the pharmacology. One is that it is an exclusive gram-positive agent. It doesn't do anything for gram-negative. It's a bacteriostatic drug, very good for streptococcus, very good for anaerobes, very good for methicillin-sensitive Staph aureus as well as Borsa, borderline resistant. It could be responsive to clindamycin, where you have to do a D test and then decide whether you should give or not. It also neutralizes toxin, reduces toxin production. So useful in toxic shock syndrome, useful in staphylococcal skin scarlet syndrome, right? But the disadvantage is that it is bacteriostatic. You can't give it for somebody routinely for bacteremia. Second is the overestimated incidence of pseudomembranous colitis. But I have not seen a case of pseudomembranous colitis. But I have talked to several experts in the US and UK. They also say the incidence is very low, very low. I don't think that generally, if you give the drug parenterally, the risk of pseudomembranous colitis is less than when you give orally. But I have not seen a case. Between oral and parenteral, I don't know, literature gives a different percentage. I'll have to refer and tell you the correct answer.
So another could be useful question from the practice. Dr. Samik Das has again come up with it. In scrub typhus situations, oral doxy, suppose it's not available, especially in dispersible tablet, would you prefer to go for azithromycin? Because that.
See, even now, doxycycline availability is not a problem. Everywhere it is available. I don't think there is any problem. But azithromycin is nearly equally effective, but doxycycline is the gold standard. I would prefer to use doxycycline rather than azithromycin, unless there is a specific contraindication for doxycycline.
Doxy is there as dispersible tablets, isn't it, sir?
It's available as dispersible tablet, available as capsule. Both are available everywhere. There is no problem in Chennai, at least I don't know. They are using left and right for all COVID adults also, doxycycline nowadays.
So that was, I believe, sir, quite a comprehensive discussion. I congratulate and thank my good friends in the platform, Dr. Sami Basu, Dr. Ashwini Sood was very interactive there, out there, and not many questions are answered by him there, but very much clear from your side in a more comprehensive manner, Dr. Nanda Kumar and all my friends. Then many more appreciations as usual from the floor. Please, sir.
Somebody has put doxycycline is not available in Kolkata. If tetracycline is available, you can use as an alternative, which is probably better than azithromycin. Tetracycline, I don't know whether tetracycline should be available in Kolkata. You can use that. Only point of caution is you should not use cotrimoxazole in strep typhus. It increases the mortality. You should not be using cotrimoxazole to anybody with strep typhus.
But tetracycline, I believe, sir, most of us will be literally apprehensive about coming to tetracycline. Having left it.
No, it's a safe drug. It's a safe drug. As safe as doxycycline. There's not much difference between the two in terms of spectrum. Only you have to give QID, tetracycline.
Few of our friends have recollected the PG Days training program in KKTC by you, Dr. Mallikarjuna Swami and others. Sir, that was an awesome session, sir, from Dr. Bala, sir. It's always been it's a learning experience always with you whenever listening to you, and not many take-home points are there, especially from the clinical settings that rather than from the textbooks from your experience. And I am sure all my participants here, who have joined us for the session, would have really benefited, and they would at least make some difference in their practice, or maybe sharing the experience with their friends across. And we would like to have more and more sessions from your side, as such an recent experienced clinician like you only can provide. Thank you very much, sir, and thanks my dear friends for joining us today and being very active in the interactive platform. And it's now time for the organizer to come back and have the concluding remarks. Dr. Shanai, Dr.
Yeah, yes, sir. Thank you very much, sir, for this informative, excellent session. We are grateful for the time and effort you took